This program is brought to you by Emory University.
I titled this talk, Getting to Safe, Affordable, Effective, Patient-Centered Care. Good data and good measures are just the beginning. That's something of a reference, the first part of that, to a very important report in the United States in 2001 called Crossing the Quality Chasm. And just out of curiosity, could you raise your hand if you know of that Institute of Medicine report, Crossing the Quality Chasm? Okay, so a good share of folks, but what I'd like to do in the time that I have is I'll provide some context for the genesis of quality measurement as an important part of healthcare in the United States. Then I'll provide to you a framework that I like to use in thinking about quality measurement and quality improvement. And then some evidence. What do we know so far about the use of quality measures to try to improve the quality and outcomes of care? So this slide here really summarizes what I consider to be the seeds of the quality imperative that we have in the United States right now. Those seeds began with a very important report by the Institute of Medicine in the year 2000 called To Err is Human. And that report really called to our nation's attention for the first time the magnitude of medical errors and even deaths from medical errors. They pointed to just under 100,000 deaths due to medical errors per year, and pointed out that that made it the 5th leading cause of death in the United States, equivalent to a jumbo airliner filled with passengers crashing every day of the year. So that really woke up this country with respect to quality in healthcare and the importance of quality and the importance of safety, and raised a lot of questions about what we could do to measure and ensure better safety and better quality of care in the U.S. healthcare system. In 2001, just shortly after the medical errors report, was another extremely important report, the one that I referenced on my title slide. That report was called Crossing the Quality Chasm. And in that report, the Institute of Medicine highlighted 6 pillars of a high-quality healthcare delivery system. And though they named those to be, they called those the STEEP, S-T-E-E-E-P, pillars. And those letters stood for safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. And they said a delivery system needs to have those 6 attributes to be truly high-performing, high-quality healthcare delivery system, and that there was not just a gap, but a chasm between where we were as a country relative to those 6 pillars and where we ought to be. Really, that was a very important turning point in America in terms of the role that quality measurement has come to play in our healthcare delivery system. Up until those 2 reports, quality measurement had really been much of an academic exercise. Things that were part of studies that were being done about healthcare quality to try to understand healthcare better and try to understand attributes of delivery systems that led to better quality, or how quality attributes led to better outcomes. But it was really just used in academic studies and published in peer-reviewed journals, had no real-world implementation. All that has changed quite dramatically in the past 10 years in ways that I'll talk about in a moment. But a final and very important piece, I think, of the seeds for that quality imperative were planted in 2003 with a very important article by a team from RAND that was published in New England Journal. That team was led by Dr. Elizabeth McGlynn. And what that team had done was to study the many, many important aspects of evidence-based healthcare throughout America, and to evaluate what percentage of the time do average Americans receive evidence-based care. And their finding was only about 50% of the time Were Americans receiving the care that they should be given the clinical circumstances that they had? So they found underuse of important evidence-based care, they found overuse of important evidence-based care, and in general found really a striking weakness in the matching up of the evidence in the clinical literature and the actual care that patients were receiving. So with those important seeds planted, the quality measurement field was kind of launched out of academic studies and into real world. And there were some growing pains, and I'll talk to you about some of those. But I also just want to draw back to the conversations I know you were having yesterday about cost, just to set that important context too. Because while quality measurement and issues around cost have to some extent dwelled in parallel universes over the last 10 years since all of those seeds of the quality imperative were planted, they have absolutely converged now in the U.S. And are inextricably linked in the ways that we'll talk about. So these two graphs that you have on the screen are just two different ways to underscore the importance of cost growth and the cost growth problem that we face. I understand from Dr. Copeland that I missed a talk yesterday about the fact that the cost growth problem faced by China is an even more severe one with, I think, a tripling of healthcare spending over the time period in which we've merely seen a doubling. But nonetheless, we have a very serious cost growth problem that has come to the forefront at this point. The top left graph there is data from our national Office of the Actuary for our Medicare program, run by CMS, the Centers for Medicare and Medicaid Services, showing the projected doubling of spending on health care in terms of per capita spending over a 10-year period. The bottom graph that you see there is actually data from Massachusetts, and specifically from Blue Cross of Massachusetts, where I work. So that top blue line there is the medical expense trend that we have seen at Blue Cross of Massachusetts from the period 2000 through 2009. So what you can see from that top blue line there is double-digit rates of increases in spending on medical care from 2001 through 2009, year after year after year. And below it, by comparison and contrast, the red line is the rate of growth in workers' earnings, and the green line is the rate of growth in general inflation. Now, all of that was kind of moving along in a way that was not exactly satisfactory, but not exactly a burning platform either in Massachusetts, up until 2006, at which time we passed a law that said that individuals must carry health insurance, and that if they don't receive health insurance through their employer or through a government program, that they need to buy it. Legislation that requires something we call an individual mandate, and that was the model for national health care reform passed in the U.S. last year. And that individual mandate, I would say, really created the burning platform for these double-digit issues to get addressed, because when individuals have to go out and buy insurance year after year without any kind of buffer between them and the real rate of increase in that insurance, it becomes a matter of very public concern, very different from the matter when employers were buying that insurance and trying to manage those costs in ways that would, change the benefit package a bit or change the cost sharing, so that individuals getting insurance through an employer might not feel the full impact of those increases. But when individuals are going out to buy their own insurance, it's just right there without anything between them and the real increases. And so this has become a very public matter that is not going away until we get it solved. So back to quality measurement and framework for quality measurement. Maybe this seems obvious, but I thought it was worth saying that some folks say you can't manage what you can't measure. Another way to think about that is that what gets measured does become what matters and what gets attention. And because of that, I like to think of three broad domains of quality and performance that we have to be paying attention to in order to have a balanced portfolio of measures. And those three domains include clinical performance measures, including clinical process measures and clinical outcome measures, patient experience measures, and measures dealing with cost and resource use. Without attention to all three of those domains, I believe that we create an imbalance in the system that could impede our ability to get to that vision of a healthcare system that will deliver safe, effective, affordable, patient-centered care for everyone. This slide here really is meant to illustrate that when various elements of quality start to be measured and attended to, improvement does generally follow. Now, some aspects of quality are much harder to improve than others. What I'm showing you on this screen are measures that address clinical processes of care. So back in that framework of three domains, falling in the clinical performance domain, and within that domain, process measures. Things like, screenings for breast cancer or colon cancer, immunizations for children. So what this graph is showing us is that over the time period from 1996, when we first began measuring these through a national program called HEDIS, through 2002, each time a new process measure got introduced and monitored nationally, there were improvements. Now, some of that was better documentation, but some of it was actually care changing and patients getting evidence-based care that they should be getting and that they weren't previously getting. So quite striking improvements over a fairly brief period of time simply by shining a light on particular issues of quality. But not all aspects of quality respond so quickly and easily. And what this slide is summarizing is the contrast between where we are with various aspects of clinical process of care and the corresponding outcomes of care. So what I'm showing you on this slide has to do with care for diabetic patients. And on the left side, we're looking at issues related to blood glucose control, with the light blue bars being the testing to monitor blood glucose, and the dark blue bars signifying control. Now, in this case, the height of the bar represents poor control. So we would like to see the dark blue bars down as close to zero as possible, representing good outcomes, representing very few patients in poor control with respect to their hemoglobin A1C levels. So what you see from that, and on the right side, we're looking at a similar framework, but for cholesterol control. So the yellow bars that are tall are the rates of screening that are getting done for patients with diabetes, and the orange bars are rates of control of cholesterol. In this case, it's good control, so we want those orange bars to be up as close as we can to 100. So what you notice there is that with respect to the processes, getting the tests done, that across our network in Massachusetts, we were getting pretty close to perfection. Over 90% of diabetic patients were getting the screenings that they should be getting, and that's a great thing. But we're far from perfection when it comes to the control of the underlying clinical metrics that are being tested for. And we'll come back to that issue of how do we use quality measurement and quality improvement efforts to actually move beyond just improving the process of care to improving the outcomes of care and the health of the population. One last piece of the framework that I'd like to share with you is that I like to think that moving beyond sort of broad standard-setting approaches, as Professor Hu was talking about, that can be used to set quality standards. And NCQA accreditation, for example, in the United States is one example of how we might set standards and how we do for quality in healthcare organizations or health plans. But moving beyond standard setting, what are the levers that we have available to us to take quality measures and actually use them to try to improve care? I think it really comes down to 4 levers, at least from the perspective of my role and what I'm responsible for doing in Massachusetts. That is, these are the 4 levers available to me in my job. One is we can measure performance and report that information to providers in our network, holding up the mirror, so to speak, to show them their performance on any number of quality or safety or outcome measures, and with relevant comparisons and benchmarks. We can attach financial incentives to those quality measures in something that has come to be called pay for performance in the United States, but providing financial incentives to care about those measures and to care about improvement on those measures. We can take those measures and report them to the public, in a sense, attaching reputations to the measures. And finally, we can take those measures and incorporate them into our products, our health plan products, in a way that gives our members a financial incentive to use certain providers over other providers, something that we call tiered products or select network products, where you use a financial incentives to steer patients to certain providers who are higher quality, lower cost, or both, over other providers. So those are really the 4 levers available to us. And the reason that the arrows around the outside are kind of increasingly hot, going from sort of a sort of barely there to a on fire red, is that I think, from a clinician or healthcare organization's perspective, these 4 things represent a continuum that is increasingly threatening and distasteful. So just holding up the mirror, performance reporting, that's fine. Attaching some financial stakes to that, well, it may or may not be fine, but we can negotiate that. Reporting it to the public, now you're starting to get to something outside of the comfort zone because reputations are at stake. Building it into our members' incentives, then you're really getting to something that threatens market share and is of serious concern. And so in my work, I have characterized the 3, apart from the yellow circle at the top, the other 3 I've characterized as high stakes uses of performance measures, high stakes for providers. And what I've said, as we moved from that academic set of years of quality measure development to the years that we're in now, where those measures are being used for real-world quality measurement, monitoring, accountability, and improvement, we have to pay attention to different things about the measures and know if they are ready and appropriate to be used in those high-stakes ways. And so let me say a few words about that. This is a set of principles that, when I first arrived at Blue Cross in January of 2007, having spent my entire career up to that point in the academic world doing quality measure development and studying things like how quality impacted patient outcomes and organizational characteristics that contribute to quality, I really recognized that there were things we had to know about measures that were important to know when you move out of the research realm and into the real world, particularly if the measures would be used in a high-stakes way. And so we put into place in January of 2007 this set of principles that told us things that a measure had to satisfy, criteria that a measure had to satisfy before we would say it was ready to be used for any of those high-stakes initiatives, pay for performance, public reporting, or incorporate it into our members' benefits. And these have really stood us very well. I don't want to walk through them in detail in the interest of time, but what I want to point out about them is that they point to both the importance of the art and science of quality measurement. And what I mean by that is the science part is the statistics and psychometrics, right? We have to know that the sample sizes for a measure that we'll get from any provider will be stable, reliable, and give us a piece of information that represents a truth that we aren't seeing just by chance because of small samples. We have to know that the variation in that measure is actually attributable to the level of the system that we are focusing our attention on, or if it isn't, that we're aware of that and we're focusing accountability there for reasons that make sense. So those are some of the aspects of the science of the performance measurement. But the art of performance measurement recognizes that at the end of the day, performance measurement is about trying to influence thinking and behavior. And in order to influence thinking and behavior, those who are going to be looking at the information, trying to take the information in, and deciding whether to act on it, have to believe it, have to think it's fair and accurate and true. And so the rest of what's captured in these principles deals with that aspect, the art of performance measurement, and things like making sure that to the greatest extent possible that the measures we're using are measures that are from a nationally accepted measure set that have been through kind of a long vetting process where, medical specialty societies have weighed in and accepted that this is clinically important and that the measure itself is a valid and accurate way to capture that important construct. And, the last criterion there is saying not only that, but that the individual providers or institutions that are being measured have to ideally have had a chance to see the measure about themselves and work with it over a period of time before the measure becomes high stakes. So starting with that yellow circle of just reporting the information before it becomes something on which dollars are attached or reputations or market share. So I'd like to think of kind of the staging of measure development, something along the lines of a clinical trial. Because we all understand that there are things that we don't learn about a medicine until it's in widespread use. There are things that we don't understand about side effects, important side effects, and maybe even harms of a medicine at the point of clinical trials because of the limited populations and the nature of the populations that participate in those clinical trials. And so similarly with performance measures, I like to say that there is that phase one of development and testing where someone has an idea for an important gap that needs to be filled in our national portfolio of quality measures. And they develop a measure and they do some testing and maybe they get a good journal article on the reliability and validity of that measure. What I think is very important to understand is that doesn't make that measure ready for prime time, ready to be used in a high-stakes way, until that measure has been through what I call phase two. That is, it's been implemented in a large-scale way, both so that, for the science and the art of it. The science, because there are things we will learn about that measure, about its psychometric properties, that we couldn't learn on the narrow population where the measure got developed. But the art, because that's the period of time where we can get broad engagement from those who will actually be measured. And we inevitably learn things about the measure that lead to improvements in the measure, in the data. So that middle stage is extremely important. And in my experience, once you have actually passed a measure through that stage, you can move on to that next stage of using the measure in what I've called high-stakes ways, without really a lot of resistance or antagonism or discomfort. Folks feel kind of ready and that's a legitimate thing to move on to do. So now let me use the last part of my time to talk about what we know so far about the uses of measures in those various ways. On this slide, what I wanted to summarize, sort of jumping to the punchline, is some of what we know about pay for performance and its effects on increasing quality, and some of what we know about public reporting. So on the pay for performance side, what we know is that financial incentives do change behavior. So if you attach dollars to a measure, particularly if they are significant dollars, you will see attention paid to that measure, and almost certainly you will see improvements on that measure. That means, in case it's not obvious, that we have to be mindful of what is not being measured. I kind of indicated that when I talked about that set of 3 domains and a balanced portfolio. There are things that, if we're ignoring them, either a whole domain or important aspects of quality within domains, they may start to erode. And there's been some evidence, in fact, that when For example, a pay-for-performance program is focused on a broad set of measures and then, drops some of those and moves on and focuses on some others. Not surprisingly, those measures that got dropped start to erode in their performance. So we have to not only think about what we are measuring, but what we're not measuring. Another important thing that we've learned from pay-for-performance efforts to date is that performance should be defined in absolute terms, not in relative terms. That is to say, rather than setting performance targets on the basis of an average or some network percentile, where by definition there will have to be losers in order to be winners, it's, I think, extremely important to define in absolute terms what is high quality on this measure. And as important as that, one of the things that we've learned is you don't really want to have a single number as a target. You want to have a range of targets. Because when you have a single number as a target, what we've discovered is it becomes a really time-consuming and fruitless contracting game. So we sit down at a negotiating table at the end of a year with appeals on a measure, if there's been one target, to talk about the denominator of the measure and how this patient, if they hadn't been in the denominator and they shouldn't have been in the denominator, we would have passed, we would have gotten all that money, and it is a large waste of everyone's time and really not the intent of performance improvement at all. So one of the things we have learned along the way is the importance of having absolute targets, but having it not be just one target, but actually a range of targets that represent good to great performance. On the public reporting side, we could sum up right now, after 25 years of public reporting of quality data, the beginning of it, clearly before those 2000 and 2001 reports I talked about, that right now, we do not have the public's attention with respect to quality data. There's a lot of performance information out there for the public. Oh my goodness, 5 minutes. A lot of information, and by and large, the public is not using that information. So we understand, quite a long way to go with measurement to make it meaningful to the general public. Here is another piece of evidence that I thought I'd share with you related to some specific improvements that came from a combination. We can't disentangle the effects of public reporting and pay-for-performance. So the measures that we're focused on this slide here are measures that have to do with patients' experiences of care. They come from California, where patient experiences were being measured over a long time period, several years, 2003 through 2006 is what's captured here. And in 2004, in 2003, public reporting began. In 2004, pay for performance on those measures also began. And we saw really significant improvements in patient care experiences, both with respect to physician communication and care coordination and several other dimensions of care through those efforts. That is striking because this is one domain of measurement, patient experiences, that turns out to be quite difficult to improve upon. It doesn't respond nicely and quickly and simply the way those clinical process measures that I showed you at the beginning. To change a patient experience and have the patient answer questions differently, think differently about their care, you actually have to fundamentally change care in ways that patients notice. And so these results really are quite striking about the effects of the combined effects of pay for performance and public reporting. A less optimistic set of results from pay for performance came from the United Kingdom, which had, folks probably are aware, a national pay for performance program with a very broad set of measures for primary care physicians. And over the period from 2000 to 2000 to 2007, this article, which was published recently in the BMJ, was showing extremely little change. In fact, no evidence of a significant impact of the pay-for-performance program on either the testing or the control, and in some other results not captured in this picture, other outcomes for hypertensives. So their evidence showed extremely little effect of pay-for-performance in their system. Some of the reasons that have been hypothesized for that have to do with both low targets, so performance targets that really, even at the outer limit, because they did have a range, as we talked about, but the high end of that range wasn't much higher than where performance already was. So that's one of the reasons that we could have seen very little real change other than what was happening in secular trends. But another was because of the allowance in that system for what they called exception reporting. Say, taking patients out of the denominator, not counting patients. They had what is considered by most folks a very lenient approach to allowing clinicians to say, this patient shouldn't qualify for this measure. So that's another one of the hypothesized reasons. But in contrast to that, I just want to close with sharing with you some more optimistic data about what can be accomplished through pay for performance. This data comes from an initiative at Blue Cross of Massachusetts where we introduced a new contract model that includes a very large set of incentives on quality, on clinical process, clinical outcomes, and patient experience measures. And so you can see both ambulatory and hospital process, outcome, patient experience measures that are incentivized. And there's a range of targets, as we talked about. And at the outer limit of performance, at that very high aspirational goal, an additional 10% is potential earnings on this contract. So millions of dollars available to these organizations for extremely high performance on this broad set of measures. And what we saw as a result of that was actually a remarkable rate of improvement across these organizations. So what I'm showing you on this slide comes from ambulatory clinical process measures, so one of the domains, and I'm breaking it into preventive screenings on the left and chronic care management on the right. The organizations that are part of this new contract with these large dollars available for improvement on these measures are shown in blue, and the rest of our network is shown in green. Now, the contract began in 2009, so that's the third of the 3 years that you see there. In 2008, there were 2 organizations that came into the contract with a 1-year kind of bridge deal into the contract. So 2 out of the cohort of organizations that were fully in 2009 were also in 2008. And so what you can see is in 2007, before the contract, roughly equal preventive care performance for the AQC and non-AQC segments of our network. The AQCs were actually a bit lower on chronic care management than the non-AQCs before the contract started. And then you can see in 2009, with all these initial organizations fully in the contract for a year, really substantial improvements in their performance, while over in the non-AQC segment of the network, very little change. So this is a combination of, I would say, 4 important factors that were there. One is the measures were well known, well understood, considered broadly by those who were on the other side of them to be important, evidence-based things that are good for patients. So no objections to working on these measures. Second thing is large dollars available for doing well on these measures. Third thing is we, the Blue Cross, were providing regular information to the organizations to help with their performance on the measures. Here's where you are so far. Here's the patients who are eligible for this measure who haven't yet received this measure. And the fourth and key factor is in every one of these organizations, they have put in place a very serious and superb leadership structure to help be the recipient of all that information and help drive improvement to those goals. The last piece of results from that I'll share with you has to do with clinical outcome measures. So remember that slide I showed at the beginning with the contrast between process and outcome. These are some outcome measures. In my mind, it was one of the more audacious things that we did in this contract was to create accountability for outcomes. So you're not just responsible for getting the process done while the patient is in your office, but actually you're also responsible for how well the patient is able to manage their condition and keep it under good control when they're out of your office, living their life, trying to manage their condition with medicines and diet and exercise and other things that you've advised them to do. But are they doing those things? And what we saw just in the first year was that these organizations not only were achieving, not only taking accountability for these aspects of care, but actually nearing the outer limit of what our data tell us is possible to achieve in terms of performance on those outcomes. That's, good control of cholesterol and A1C and blood pressure for diabetics and patients with cardiovascular disease and hypertensive patients. So that really was a very optimistic and striking finding from our perspective. So I will, unfortunately, stop there and be glad to take your questions. Thank you.
The preceding program is copyrighted by Emory University.